Hi, I'm Lindsey Smith, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. Today, I'm honored to welcome Dr. Joanne Liu to the podcast. She brings decades of experience on the front lines of humanitarian crises around the world. We'll draw on her unique perspective to better understand the challenges we face now and those that lie ahead. Dr. Liu served as the international president of Médecins and Frontières, also known as MSF or Doctors Without Borders, from 2013 to 2019. During her time at MSF, she led responses to major humanitarian and health crises, including the 2014 Ebola outbreak. She shares powerful insights from these experiences in her new memoir, Ebola, Bombs, and Migrants. Dr. Liu is currently a professor at the School of Population and Global Health at McGill University, where she also directs the Pandemics and Health Emergencies Readiness Lab. In addition, she serves on the World Health Organization's independent panel on pandemic, preparedness, and response. Dr. Liu, thank you so much for joining us today.
Thank you.
I'd like to start with learning more about you and what first got you interested in medicine, specifically pediatric emergency medicine.
I basically decided to go into medicine after I've done a stay in West Africa. I did some international cooperation with Canadian Crossroad, and I stayed in Mali for 3 months. And after I came back, say what I've saw in terms of needs in the general population, I decided that I will go into medicine and work overseas with, I would say, the most vulnerable population or people in times of crisis.
And how did you kind of land on pediatrics?
So I remember when I was working overseas and I said, oh, there's so many children here. And I just said, I should not run out of patients. And so I always thought that as well, when I did medicine, they were about the best patient you can have. They, most of the time, recover very well with no sequela. And B, when they're not sick, they start to play and eat. So I thought it was pretty easy compared to adult.
That's amazing. Thank you so much for sharing how you got into medicine. And I understand that you knew kind of at an early age that you wanted to eventually join MSF. Can you talk a little bit about that?
Sure. So I wanted to join MSF. I think the seed was planted when I was reading as a teenager during my quest for meaning in life, different books. And one of the book I read was Peace in the World, Doctor. And it was a doctor, actually a surgeon, working with Doctors Without Borders, Médecins Sans Frontières, MSF, in war zones. And I remember when I read that, I said, wow, I said, this person is making a difference in the most improbable situation, in most improbable site and context. And I thought that was very, very interesting. And then as well, I read another book that really stayed with me and that I really love, which is The Plague for Albert Camus. And I remember in the book, it was the doctor who was trying to care for patient who had plague was asked, what is driving you? Why do you keeping on? And the doctor said, there was hesitation. And then the other person added, and all your patients die. You don't make a huge difference. And in addition, you don't even believe in God. And then the doctor said, I never got used to death. I don't know more. And I remember when I read that, telling myself, I will never trivialize death and I will fight for life. So medicine became a very simple answer to my quest.
Thank you so much for sharing that personal story. And I love that those books inspired you. Let's dig a little bit more into your involvement with MSF. I understand that since 1996, you've been involved with them, went on to serve as the international president for 7 years, a remarkable journey indeed. But what motivated you to take on that leadership role at that global level?
Well, I think that I've done a fair amount of field assignments. I noticed that the Médecins Sans Frontières Doctors Without Movement was really growing. And I was concerned that basically the infrastructure or the offices in the global north was almost growing faster than our operation in the field. And so I figured out that I wanted to make sure that we don't lose the essence of what is MSF, which is actually bringing medical aid in the worst and hardest and toughest places of the world. So that that's what I wanted to make sure that we don't lose in the process of modernizing our support and increasing the places where we were doing raising and as well hiring for international staff.
Your willingness to step into some of the world's most challenging environments, I think, says so much about your courage and your commitment to humanitarian care to really kind of create that deep purpose of meaningful change. So, thank you for all of your work there. I want to talk a little bit about your book, Ebola Bombs and Migrants. What was the inspiration behind that book to write it? And talk about some of the key themes that you hope the readers take away from it.
Thanks for the question. Yeah, the book, it's been a long journey, like anyone who has written a book, I guess. This is what I call sometimes FBI. In French, we say fausse bonne idée. It's a good false idea in a sense that you think it's going to be good, but actually become a big, big thing. And so it took me a while to put that together. But I think what pushed me to do that was the fact that when I was the international president, things went so fast that I had the feeling that I didn't have a chance to somehow reflect on what happened and really harness all the lessons to be learned. And so I just said, well, then I'm just to somehow, I would say, get over my hangover of leading MSF. I would write a book and reflect. And so the idea, I would say the premise of the book is, I think that since 9/11, I say that because everything was less crystallized around that, but we live in times of fear. Fear has brought what I call the security obsession. And our security obsession is actually eroding our solidarity mechanisms in the world. And by eroding our solidarity mechanisms, when we come in response to crisis, we respond late. And I bring three cases: the Ebola outbreak in 2014, 2016 in West Africa, when we only answer when we felt threatened as the global noise; the attacks on hospital, where we see the enemy everywhere, and we are basically violating the international humanitarian law; and the migrant crisis. Today, we portray migrants as an existential threat to our identity, to our economy.
That's incredibly powerful. Thank you for sharing that. And I think what I noticed in the book is that it's a reflection on the past, also some learnings and a call to action, and the key themes that you highlight: Ebola, the attacks on hospitals, and the migrant crisis, all deeply are relevant, especially in today's world as well. So let's talk a little bit more about the Ebola outbreak. Can you describe how your team was often limited to providing palliative care, overwhelmed by the sheer number of infections and lack of effective treatment at that time? And maybe just take us back through that time period and the crisis, on how countries were responding and some of the key challenges that you faced to try to drive a more effective response.
Right. So the Ebola outbreak in 2014, 2016, I think we have to bring ourselves back to those times, because back then there was no vaccine, or there was no specific treatment for Ebola. And as a reminder, Ebola is a hemorrhagic fever, and 50 to 70% will die if they have it, they get infected. And so what happened in West Africa, it was the first time of all the time that we have such a massive outbreak. The biggest one before that was in Uganda in 2000, where there were 400 cases, 200 survivors. In 2014, 2016, there were more than 27 people infected and 11,000 people died. So massive. And so what happened is, true time, because of the such high case fatality rate, very few people, very few organizations kept the know-how how to treat people with hemorrhagic fever. And so we kept it at MSF because we were doing all sort of different outbreak of hemorrhagic fever, from Marburg to yellow fever and Ebola. And so what became clear after a while was the fact that we didn't have enough bed for Ebola. And the importance of having Ebola bed, that we used to call it, is the fact that a patient needs to be isolated. Because if he's not isolated, then it will stay in his family, and then it will infect other people. And so it was as preventive as well a bit, curative, because back then we didn't have specific treatment to send in. Was only supporting treatment. And so what happened is very early on, we realized that all the center were overwhelmed. The one that MSF was running, but the one that the different minister of health were running in the three countries affected. So at one point, we realized we needed more hands-on. And one of the, I would say, toughest discussion, I would say, decision that was made in late summer 2014 was to take one of our best elements in each of the center that we were running, and then taking them and put them in a training center, because it was the only way to scale up the number of people with know-how about treating patients. And so that was one of the tough ones. The other very tough decision was every time we were briefing someone, we just say, you go into West Africa, but the reality is we might not be able to medevac you if you are sick from Ebola, but if you're sick from any other illnesses, because nobody wanted to take back people in their country right away. They wanted them to be in quarantine for 3 weeks. And sometimes people were being kept in a country. They would stop over somewhere. So that was as well the challenge. And the other one was the fact that a whole, I would say, region was falling apart. And we could not just let, like I said in the speech that we have written for the United Nations General Assembly, we cannot let people die on their own. We need to run in the burning building and go in and save people. And that was a call we made in September 2014 to the rest of the world.
Thank you for walking us through that time period where we had no vaccine, no treatment at the time, combined with the high fatality rate. I think your account really underscores how critical leadership, the coordination, like moving people to different training facilities, and the early action are so important in global health emergencies. So thank you so much for sharing that. I've heard you say before that while new pandemic threats are inevitable, whether they turn into a full-blown global crisis often come down to political decisions. And so I want to ask you, do you think that we truly learned what we needed to from past outbreaks like Ebola? And did those lessons improve our response to COVID-19? And then looking ahead, do you think we're any more prepared for the next pandemic that's to come?
We often say I'm part of the independent panel for pandemic preparedness and response. And one of the key, I would say, top-level message that we always put forward is a pandemic is a political choice. We will not be able to prevent an outbreak or an epidemic somehow, but we can prevent an epidemic to becoming a pandemic. And that's a choice, a political choice. It's to basically to take over the epidemic where it is. And it means quick and early, I would say, action. Instead of waiting something like it happened in West Africa to fester and become out of control. With respect to Ebola, what is great is people seem to forget, but there were a huge legacy from the Ebola outbreak in 2014, 2016. One of the biggest one is that people realized that we were not ready collectively. Like people were ready to go and send money, but what they were not ready was to go and give hands-on help if necessary. They just say, you know what? We give you money, you take care of it. Don't bother us. Don't bring Ebola back to our home. So, and then people realized that was not good enough. So they said, oh my God, if there's another type of scenario like this, how are we going to do? And one of the things that we did back then, which is one of the big, I would say, legacy of the Ebola outbreak, was what we call the research and development blueprint of the WHO, which basically gave the way forward on what are the different viruses that have potential to become a pandemic and for which we need to develop what we call medical countermeasure to fight them. And so that was one of the things. But the other thing that came very, very clearly obvious to everybody was we need to be sharing new knowledge in a timely fashion, in real time. And so this is what happened with COVID-19 to a certain extent, with the sharing of the genomic sequencing very early on in January 2020. And so now people say that, yes, we need to share early the genomic sequencing, one, but B, we need to share in real time the discovery as we are making them in order to fast track discovery collectively, and then to as well get a new medical countermeasure, be it a diagnosis, a treatment or a vaccine. So I think this was learned. I don't think that, I think sometimes I often say that we have some difficulty in learning because this seems obvious, but we don't implement it, as it should be. I think that this happened partly for COVID-19, but as well, I think that the understanding as well of, how can I say, applying what I call the precaution principle did not happen with COVID-19. We were such in denial. I thought it was very, very surprising that it took a long time for the WHO to acknowledge that what aerosols, and so therefore we should wear a mask and N95. And so we learn as well that the leadership of the WHO in those instances and giving guidance in a timely fashion is absolutely essential for the planet. So we learned a lot of things. Will we be able next time around to fast track everything? We did for COVID-19. This will be my last point on this. It took 6 months to declare a public health emergency of international concern with Ebola in 2014, 2016, but it took only 6 weeks for COVID-19. So yes, we're learning.
I think it's encouraging to hear where the progress has been made there with the blueprint, sharing information and the discoveries in more real time, but also a realization that gaps might still exist with the implementation and the timely guidance. So thank you so much for sharing your insights on that. Also in your book, you talk about the attacks on medical facilities, especially the bombing of an MSF facility in Afghanistan in 2015. After that, you led an effort to pass a UN Security Council resolution on the protection of patients, clinical providers, and humanitarian personnel in armed conflicts. But this still seems to be a problem. What is preventing an end to these attacks, do you think?
Yeah, that's the question of the hour. Thank you very much for that tough question. I think that one of the reasons when we decided to talk profusely and publicly about the attacks on Kunduz on the 3rd of October 2015 was the fact that this attack was a bit different from the others. There was an insisting aspect to it. 5 airstrikes on the principal building of our trauma center in Kunduz, in northeast area of Afghanistan. And so what was interesting is, although we had given our GPS coordinate, although we were in contact with all the different parties at war, we were not able to unplug what was happening. We called everybody. We called the Pentagon. We called the Allied, the coalition. We called the Taliban. We called everybody, and we just could not stop it. And so what became clear to us is to say, practically speaking, we need that kind of sort of red phone if something happened. But in addition to that, we need to get a political signal that there's still rules of war, that it's not a free-for-all, and that we would try to spare the civilians. We seem so far from 2015, 2016, where back then, when we passed the resolution on the 3rd of May, 2016, it was unanimously voted by the Security Council, and 80 countries backed the resolution. But as I'm speaking to you, every day or every other day, there's a medical facilities who's being bombed today. And I think why is it happening is because we are letting it happening, because there's no political cost. If there were political costs, if people were upholding to the international humanitarian law, and then we'll tell people, you have to stop that, and there are consequences if you do not respect, I think there will be a little bit more compliance. But when we let full impunity reign, what can you expect? And in addition to that, I always say, because to tag it to the third topic of my book on migrants, if you have and you let total war to happen, not sparing the civilian, you cannot be surprised that people are fleeing. People will flee if they don't have a place to hide, if they don't have a place to be cared for, if they don't have a place to heal, they're going to flee.
It's heartbreaking that those risking their lives to provide care still aren't truly protected. I think it highlights the gap between policy and actual protection on the ground. And then on the second part of your answer, you touched on my next question. The other major subject in the book is the refugee crisis, which started to be felt more acutely in Europe during your time at MSF, but which has obviously continued to grow over the years and something we're still seeing today. What's your assessment of how nations have responded to the ongoing crisis, and what should they be doing differently?
It's interesting because the phenomena of people moving around is something that happens since the beginning of the times. People do that for survival. That's normal. Animals, but human being as well. So what happened is it was really there was some sort of record numbers in 2015, and some of it was linked to the war in Syria. I would say tag as a crisis because basically people were knocking at the door of Europe. There's been other places where there've been massive displacement, but when the global north get affected, then it becomes labeled as a crisis. But it's true that we are record number of people being migrant, meaning living outside the country where they're born. But there's about 120 million people that we call being in forced displacement, and they are in forced displacement for different reasons. They might be fleeing violence, or they might be fleeing persecution, or famine, or economic issue, or natural disaster. But it's there, it's real, it's happening. And the reality is, as I said earlier, I think the way we wage war will make a difference because if we were sparing the civilians in war zones, I think that would at least decrease a certain number of those people in forced displacement. And I think that it's how we felt our responsibility and solidarity in for countries who are struggling. Because a lot of people talk about the pull factors, what attracts people to come, versus the push factor. But if we don't fix the push factors, which is the violence, the insecurity, the economical opportunities, people will continue to flee. Like many people were saying, migrants, you know what? It's better to be somehow illegal in a high income country and get money by, I don't know, cleaning houses or taking care of a garden than living under the bomb or under the cartel violence in some countries. And so when you hear firsthand those stories, you understand that nobody leaves because they have a choice. It's a no choice. It's a choice of survival.
I think the pull versus push factor that you mentioned is a really important point here, and that nobody leaves by choice. I think we're seeing a lot of this today. I want to kind of switch gears a little bit and talk about the systemic causes underlying humanitarian crises and the inadequate response to them. First of all, do you think that there are systemic causes, and do you think the response that has been given thus far has been inadequate?
Well, that's a bit of my competences about the systemic crisis. By definition, being a humanitarian aid worker is you respond to the need of people, and you don't go into the causality of things. But of course, is we do see that some of our way of living and economical predation uh, as a cost on some more vulnerable population, and so we are part of the problem to a certain extent, and it's not only that they have a problem, is we collectively have a problem, and we would need to address them collectively. And what is and I think that right now the circumstances is pushing us to do that just because of climate. The climate is everybody is responsible for the warming, and everybody's going to need to do something, and we cannot do something only in one corner of the planet. Collectively, we're going to need to do something to decrease the speed of the global warming of the planet. If we don't do that, then every day we will have heat wave, we will have wildfires, we will have all sort of different natural disaster that we will basically will exhaust our capacity to respond.
Thank you for sharing your perspective of what's getting in the way of a stronger, more effective response when these crises do happen. I agree, we collectively have a problem on a lot of these issues. I want to talk about kind of an interesting question that we have for you. In the humanitarian health field, about aid or organizations maintaining their neutrality to preserve access to care versus publicly advocating for certain steps to be taken to make providing that care easier or more effective, which could provoke a negative response from the political entities involved. What are your thoughts on that?
Well, I think that in some circumstances, what I have witnessed is that the excuse of neutrality has been put forward in order to not act or in order to not name things. And at the end of the day, I think we have to be careful. One of the things I used to say when I was international president, I still say nowadays, is if your operational principle of neutrality, independence, and impartiality is preventing you of treating a patient, you should go and ask yourself and revisit and reflect a little bit on your principles. So that would be my little piece of advice on that. I'm a humanitarian aid worker, as I said, and I respond to need of people. And as the basic principle is we care from both sides of a conflict. What is happening nowadays because of asymmetric conflict, sometimes in some conflict you only work on one side because the other side doesn't need help or doesn't want to have any support or help.
I think that's a really important perspective on neutrality. And I think it highlights the tightrope humanitarian organizations have to walk while trying to protect access while also staying really true to their values. So thank you for sharing that. Also, in your book, you relay experiences you have had providing care for young people who tell you that they have no hope for their future and don't want to have children given the state of the world. Tell us about that and your response to them in those difficult moments.
Thank you for this question. It's actually interesting because I'm a pediatric emergency physician and I started working in ER more than 30 years ago. And then what is clear to me is the fact that in my ER, when I started, having children being, I would say, distressed by what is happening to them was seldom. I would get one case a week. Now per shift, I get between 2 to 4 cases of kids who tell me, I don't want to leave. I don't want to have children. I cannot project myself in the future. There is no future. You hand over to us a planet that is not working. And so one of the reasons why I wrote this book was the fact that I wanted to tell those young kids, listen, we've tried. And of course, we're not handing you a perfect planet. The planet is really sick. On the other hand, we try, and I still think that it's worth trying, even if what you're going to bring forward would be imperfect solution. I always say that an imperfect solution is much better than no solution, as long as you're not complacent with this, I would say, imperfect solution.
I think that's a real reality that you have to sit with, and your ability to hold space for those feelings also serves as a reminder that sometimes the most important act is empathy. I think I heard a lot of empathy come out in your answer there, to listen, witness someone's pain, let them feel seen and heard, and maybe not have the right answers or a perfect solution, but being present with them and reminding them that they're not alone.
Well, I every time when I see those children in my ER, I just tell them that to hang on and give it a try. I just say that it's better to fail while trying than to fail for not doing anything. It's the way I am. I'm a person who's always in action. So that's what I hope I'm going to transmit to the next generation.
That's a great tie-in to our next question. So at Osmosis, we have many students, early career health professionals in our audience. You offered some good advice already throughout this podcast, but wanted to give you an opportunity to give them more advice about getting involved in humanitarian health work during their careers.
Oh, I think that they should get involved. I don't think that being involved at the front line of a conflict is a fit for everybody, and it's fine. But I think that everybody can contribute from where they are. There are no big or small contribution. There's only contribution as far as I'm concerned. And I think that all of us can do our little bit to make things a little bit better around us. What I wish them is to have I would say, the strength, the lucidity, and this sort of kick-ass spirit to move things around and get it better.
I've heard you say before that every patient has something to teach us. So we wanted to share that little nugget of advice as well. And then just recap that, you might not need to be on the front lines, but there is some way, somehow to contribute today. So thank you so much for sharing that to our audience. Before we wrap up today's episode, I just wanted to give you a chance to maybe touch on anything that we maybe didn't cover that we should have.
Well, I really do think that it's easy today to want to give up. And my last thing is just say, don't give up, just give it a try. And then often you might not see the result of what you're doing right away, but you will have, I would say, move the line a little bit and then to allow the next to continue. And this is how we change things. Like, remember, like I started medicine and people were smoking in my hospital doing war rounds. There were an ashtray in the hallway. And now you cannot even smoke around the hospital 8 meters from it. So things change. You just need a little bit of patience, but no complacency.
Don't give up, because that is how change happens. That is a powerful note to end on, Dr. Liu. Thank you so much for sharing your time, insights, and experience with us today.
Thank you very much.
Thank you so much, Dr. Liu, for joining us today. During your time at MSF, you led the organization through major humanitarian emergencies like Ebola, championed innovative solutions such as telemedicine, advocated fiercely for the protection of patients and medical facilities in conflict zones, and provided hands-on care in some of the world's most challenging settings. With 25 years of experience in emergency clinical care, policy and global health, and diplomacy, you continue to inspire us to do more and to do better in an increasingly divided world. We're deeply grateful for your perspective that you've shared with us and the powerful reminder of what's truly at stake. To learn more, be sure to check out our memoir, Ebola, Bombs, and Migrants. I'm Lindsey Smith. Thanks for tuning in. Let's all do our part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.